Good morning. We will continue our nephrology Passmedicine questions. Um, the first question today, you review a 42-year-old woman 6 weeks following a renal transplant for focal segmental glomerulosclerosis. Following the procedure, she was discharged on a combination of tacrolimus, mycophenolate, and prednisolone. She has now presented with a 5-day history of feeling generally unwell with anorexia, fatigue, and arthralgia. On examination, her sclera are jaundiced and she has widespread lymphadenopathy with hepatomegaly. What is the most likely diagnosis? Is it hepatitis C, Epstein-Barr virus, HIV, hepatitis B, or cytomegalovirus virus? So this 42-year-old woman, after renal transplantation, 6 weeks after renal transplant, um, she received a combination of tacrolimus, mycophenolate, prednisolone. She has now anorexia, fatigue, arthralgia, and jaundice. The most common cause of these manifestations is cytomegalovirus virus. It is associated with immunosuppression after kidney transplantation. Okay. The cytomegalovirus virus is the most common and important viral infection in solid organ transplant recipient. The treatment of cytomegalovirus virus is by ganciclovir. I will talk about renal transplant, HLA typing, and graft failure. The human leukocytic antigen HLA system is the name given to the major histocompatibility complex in humans. It is coded for on chromosome number 6. Major histocompatibility complex in humans present on chromosome number 6. Some basic points about the HLA system. Class 1 antigens include A, B, and C. Class 2 antigens include GB, GQ, and GR. When HLA matching for renal transplant, the relative importance of the HLA antigens are as follows. GR is the most important, then B, then A antigen. Graft survivor for first year about 90%. 10 years 60% for cadaveric transplant, while in living donor transplant the graft survivor in the first year will be 95%. The next 10 years will be 70%. What are post-operative problems? Post-operative problems of renal transplantation: acute tubular necrosis of the graft, vascular thrombosis, urinary leakage, and UTI. Hyperacute rejection, it takes place minutes to hours after the kidney transplant operation. The cause of hyperacute rejection mainly due to pre-existing antibodies against donor HLA type 1 antigen, or rarely seen due to HLA matching. Okay, mainly due to mismatch against type 1 HLA. Acute graft resection, acute graft failure, or acute graft rejection less than 6 months. Okay, usually due to mismatched HLA, and it is cytotoxic T cells, cell mediated rejection. Other causes include cytomegalo infection, may be reversible with steroids and immunosuppressants. Causes of chronic graft failure, which takes place after 6 months from the operation. It is both antibody and cell-mediated rejection. It causes fibrosis to the transplanted kidney. Recurrence of the second cause, recurrence of original renal disease, minimal change glomerulonephritis, then IgE, then focal segmental glomerulosclerosis. Okay, the next question. A 54-year-old woman is admitted to the emergency department following what sounds like an episode of vasovagal syncope. Blood gases on admission show metabolic acidosis. Blood tests are reported as follow. Sodium 143, potassium 3 millimole per liter, chloride 116, bicarb 18. From this blood tests, we will measure the anion gap. In the question, he mentioned that the patient has metabolic acidosis in EBG, and he gave us the anions and the cations. So we will measure the anion gap by measuring the sum of anion and subtracting the sum of cations from it. Urea is 4 and creatinine is 88. Which one of the following is most likely to explain the metabolic acidosis? He will give us some causes of the metabolic acidosis, mostly high anion gap and low anion gap causes. According to the measured anion gap, we will answer this question. The choices are lithium overdose, aspirin overdose, recent myocardial infarction, alcoholic ketoacidosis, urethrosigmoidostomy. This 54-year-old woman which had metabolic acidosis, after measuring the anion gap, the anion gap is normal. Okay, it is about 12 millimole per liter, and this is normal anion gap, not high, and is consistent with urethrosigmoidostomy. While aspirin overdose, myocardial infarction, alcoholic ketoacidosis, these are causes of high anion gap metabolic acidosis. So the correct answer is urethrosigmoidostomy according to the measured anion gap. Okay. We will talk about metabolic acidosis. Metabolic acidosis is commonly classified according to the anion gap. This can be calculated by sodium plus potassium minus cations, which are represented by chloride and bicarb. If a question supplies the chloride level, then this is often a clue that the anion gap should be calculated. Normal range of anion gap is 10 to 18. Normal anion gap or hyperchloremic metabolic acidosis. Causes of normal anion gap: gastrointestinal, bicarb loss, diarrhea, urethrosigmoidostomy, fistula. Renal tubular acidosis also cause normal anion gap. Drugs such as acetazolamide, ammonium chloride injection, and Addison's disease. While causes of raised anion gap: lactate, and this is present in sepsis, hypoxia, shock. Ketones in diabetic ketoacidosis and alcoholic ketoacidosis. Urate such as renal failure, acid poisoning, by salicylates and methanol. Okay, metabolic acidosis secondary to high lactate levels may be subdivided into two types: lactic acidosis type A. Causes of lactic acidosis type A are sepsis, shock, hypoxia, and burns. Lactic acidosis type B, which is caused by metformin. Okay. Uh, the next question is 14-year-old girl is referred to a pediatric unit with reduced urine output and lethargy. She has been passing bloody diarrhea for the past 4 days. On admission, she appears dehydrated. Blood shows the following: sodium 142, potassium 4.8, bicarbonate 22, and urea is 10.1. Creatinine was 176. Hemoglobin level was 10.4. MCV 90. Platelets 91. Or 91 to the power of 9. White count is 14.4. Okay. What is the most likely diagnosis? Which one of the following organisms is the most likely cause? Is it Campylobacter or Giardia or E. coli or Salmonella or Shigella? This young age female, which is referred to pediatric unit with achy eye and bloody diarrhea. It is typical HUS, hemolytic uremic syndrome. She will present with thrombocytopenia, hemolysis in the blood, and achy eye, which is presented by oliguria and lethargy and elevated urea and creatinine. Okay. So the main cause of typical HUS is E. coli. Hemolytic uremic syndrome, classically caused by E. coli strain 157 H7. Okay. Hemolytic uremic syndrome is generally seen in young children and produces triad of achy eye, thrombocytopenia, microangiopathic hemolytic anemia. Most cases are secondary to typical HUS. Classic Shigella toxin producing E. coli. It is enterohemorrhagic toxin. This is the most common cause in children, accounting for over 90% of cases. Other causes of typical HUS, pneumococcal infection, HIV, and lupus, drugs, cancer. Primary HUS, which is atypical, is due to complement dysregulation. Investigations of HUS, full blood count will show anemia, thrombocytopenia, fragmented blood film. Renal function will show elevated urea and creatinine, and stool culture to diagnose the E. coli infection. Management of HUS treatment is mainly supportive by fluids, blood transfusion, and dialysis if required. There is no role for antibiotics despite the preceding diarrheal illness in many patients. The indications for plasma exchange in HUS are complicated. As a general rule, plasma exchange is reserved for severe cases of HUS not associated with diarrhea. The eculizumab, which is C5 complement 5 inhibitor monoclonal antibody, has evidence of greater efficiency than plasma exchange alone in the treatment of adult atypical HUS. Which one of the following is least recognized as an indication for plasma exchange? Uh, this is very simple question. He will give us some cases or some diseases which are indicated for plasma exchange, and only one of them is not indication for plasma exchange. Guillain-Barré syndrome, and it is a common indication for plasma exchange. Church-Strauss syndrome, myasthenia gravis, cerebral malaria, and Good-Pasteur syndrome. Of course, the answer will be cerebral malaria. Cerebral malaria isn't a standard indication for plasma exchange. Plasma exchange have been tried, but it is generally only justified when peripheral parasitemia is greater than 10% of circulating erythrocytes. The role of blood transfusions remain controversial, as they are both expensive and potentially dangerous in many malaria areas. We will talk about plasma exchange, indications of plasma exchange or plasmapheresis will be Guillain-Barré syndrome, myasthenia gravis, Good-Pasteur syndrome, ANCA-positive vasculitis. In cases of RPGN, rapidly progressive renal disease or pulmonary hemorrhage, TTP and HUS, cryoglobulinemia, and hyperviscosity syndrome secondary to myeloma. Complications of plasma exchange are hypocalcemia due to presence of citrate used as an anticoagulant for the extracorporeal system, metabolic alkalosis, removal of systemic medications, coagulation factor depletion, immunoglobulin depletion. Thank you, and we will continue in the next session.